Well, minimal HE is the mildest form of hepatic encephalopathy, with an estimated prevalence between 30 and 80% in patients with cirrhosis. And despite showing no clinical symptoms, patients with these conditions have an associated impaired health-related quality of life. Minimal HE predicts the development of overt HE, and it is also associated with poor survival. And these are among the reasons why, for the recommendation of screening and treatment of minimal HE in patients with cirrhosis. As you all know, ammonia plays a key role in pathogenesis of minimal HE. Ammonia is constantly generated in the gut by some enteric bacteria and by incorporated through diet ingestion. And in normal conditions, most of this ammonia is detoxifying the liver through the urea cycle. In cirrhosis, liver function is impaired, and greater amounts of ammonia enter systemic circulation and reaching the brain, where it is detoxified as glutamine and contributing to the development of HE. As I mentioned, several enteric bacteria are natural producers of ammonia, and we know that the intestinal microbiota shifts during fibrosis progression, and it's been reported to account for intestinal bacterial overgrowth and increased intestinal permeability, which are suggested mechanisms of bacterial translocation in cirrhosis. So with this background, we present here preliminary data on a very neat study just aimed at evaluating bacterial antigen translocation in patients with cirrhosis and minimal HE to try and correlate serum ammonia levels in these patients with antigens from translocated bacterial species from the gut. The study includes patients with minimal HE diagnosed using the FRESH score from two centers in Spain, Hospital Universitario Balme de Sevilla and Hospital de Alicante. And we recorded all clinical analytical data and evaluated DNA and endotoxin as bacterial antigens, and we measured serum levels of ammonia and nitric oxide. These are clinical characteristics of our patients, 40 so far, mean age 60 years old, most of them men, main etiology alcohol, and around 30% of them with acidic fluid, most of them also child B. And these are some of the analytical characteristics of our patients. So regarding all our experimental results, we evaluated first the bacterial antigens. First one, serum endotoxin levels, and as you can see here, we had a wide variability in data, which we consider it was due to the rate of bacterial translocation we have in cirrhosis. We observed 30-something% of bacterial translocation in cirrhosis evaluated as the presence of bacterial DNA in blood. This rate is very similar to what we found in patients with cirrhosis without minimal HE. And we confirmed that when we split patients into those with bacterial DNA, there were clear-cut differences in the amount of serum endotoxin between them. Regarding ammonia and nitric oxide, we observed similar results when we distributed patients according to the presence of bacterial DNA in blood. We observed significantly increased amounts of serum ammonia and nitric oxide in patients with bacterial DNA. Levels of ammonia and nitric oxide in serum correlated in the overall series of patients, but when we studied patients according to bacterial DNA, we observed how this correlation was exclusively due to the subgroup of patients with bacterial translocation. We then studied the correlation between serum ammonia and our bacterial antigens. We observed again that the DNA positive population was responsible for the overall correlation we observe here in the comparison between ammonia and LPS in the whole series of patients. Well, among patients with bacterial DNA, we also measured the amount of bacterial DNA that was being translocated, and among these patients, the concentration of amplified bacterial DNA also correlated with serum ammonia in serum of patients with cirrhosis and minimal HE. The results for nitric oxide were pretty much the same. Only here, difference is that residual levels of LPS also correlated with serum ammonia levels in patients even without bacterial DNA translocation. And we then try and correlate this experimental data with the neurophysiological status of these patients. I'm sorry, the graphics just didn't like PC. They come from Mac. And we can see here the effect of these bacterial antigens on the FES score, which is none, basically. There were no differences in the FES score according to the amount of LPS detected in blood. And we observed, so I can see here, yeah. Patients with bacterial DNA show a worst FES score, but this difference was not statistically significant. It was almost there. I think we need like 10, 15 more patients to get there. And this is our correlations between ammonia and nitric oxide with the FES score. And we had here an interesting result. We had a weak correlation between serum ammonia levels and the neurophysiological score in patients with bacterial DNA, suggesting that, well, here, inflammation probably related with bacterial translocation is contributing somehow with serum ammonia to the neurophysiological impairment. And we didn't see this correlation on nitric oxide or in patients without bacterial DNA. So the conclusions of this preliminary data are these: bacterial antigen translocation into blood is associated with significantly increased amounts of ammonia and nitric oxide levels in patients with minimal HE, and maybe bacterial antigen translocation may constitute an add-on, something that is additive in minimal HE that may contribute to the neurophysiological impairment. Sorry. I'd like to thank people from Manolo Romero's group in Sevilla for their contribution to this work, and of course thank you all for your attention. Thank you.